Thank you very much for your nice presentation, and I would like to thank the organizers to invite me to explain our experience in Barcelona, in Spain. These are my disclosures. And first of all, I have to explain that our context maybe is different, whereas HIV testing is done voluntary. That means that people have to consent if they are offered an HIV test. So this is a different situation. And the other situation, the other difference maybe, or the context in which we live, is that I showed this very old slide from UNAIDS, which says, know your epidemic, and then you know your response. And this is from probably 2008, and I think it's still worth to think about it. Because in Spain, that is the high blue line, the main transmission is in men who have sex with men. Now, men who have sex with men includes also heterosexual men who have sometimes sex with men. So it's a broad definition. Also, if we see it's now a main way of transmission, it not always have been that way. I mean, if you look at the statistics like 15 years ago, I mean, the number was not as high, basically because nobody, when they were diagnosed, explained the way they might have acquired HIV infection. Also in Catalonia, the part of Spain where Barcelona is placed, men who have sex with men is the main way of transmission. And that is the reason why in 2006 we created a community center for MSM and transgender women just to increase uptake of HIV and STI testing. Remember, when we talk about 1919, the biggest gap at that moment were to find people who were living with HIV. I mean, the medical situation was working all right. People were starting quite early treatment, but there were still a lot of people who were living with HIV and didn't know that. So we found, we were doing already testing in our organization, but we found that most of our positive results were given in men who have sex with men. So that was the reason we created the community center. And there are a lot of definitions about community centers, but we think that it should comply a number of factors, like it should be peer-led. People who come to the place has to talk to equals, to their peers. It makes it easier. It creates a safe environment where it's easy to talk about your sexuality, where you won't be judged about what you're doing. And finally, another issue which I think is important is incorporating point-of-care testing. So that means testing where you have results at the same day, at the same moment, hardly. Now, in 2006, we introduced for the first time in a non-clinical setting the rapid HIV test. And here you see some results where you can see, let me see if I do this right. Here you can see all centers till 2006 did around 1,000 tests. And then after introduction, you see how really the testing went up. And these are the results of Barcelona checkpoint. So we started in 2006, but we got up to around 12,000 tests, which we do yearly. Do we do that on the same persons? No, you can see the number of clients, that's the red line, is also increasing. And the green line shows people who come during the year for the first time to the center. So there are new people coming in. So this 12,000 tests represents 4% of all tests done in Catalonia. in hospitals, public hospitals, private hospitals, just 4%. But with that 4%, we are detecting around 1/3 of all HIV cases reported by the system. So it's really very, very cost effective. And then in 2015, we introduced the use of PCR testing, point of care PCR testing that takes 90 minutes. And we also introduced the CD4 count. So, because if you are doing a rapid test and it is a reactive test, then you have to confirm that. And so most of the time that means that you have to take blood, or you have to send the people to another lab, and that takes like 1 week. And you will lose people. You will lose like 30–40% of the people. So what we decided is to introduce, in this case, the GeneXpert. It's a qualitative PCR test. It takes 90 minutes, and we confirm at the same moment a positive reactive HIV rapid test. We also do the CD4 counts to see how is the situation of the person. That takes 20 minutes. These results were published in 2018 in the HIV Medicine. Now, if the result is confirmed, there's a lot of other steps we are doing. First of all, emotional peer support. You said there's a change, and I agree completely, but still, for a lot of people, to receive a diagnosis is an important impact in their life. So the first thing, when we get a confirmation, we work on the emotional part for the person, and that helps them when they get to the hospital, that the doctors and nurses don't have to work that part. They are already prepared about the situation. They already know what is it, what's the best way to take treatment, etc., etc. So the linkage of care is also an important part, but because we know that people who are HIV diagnosed are still young of age. It's between 33 years is the average age, meaning that people of that age never have been in a hospital. It will be the first time they will go to a hospital. So it's not sending somebody to the HIV unit in a hospital. It is making an appointment, giving a date, a time, a name of a doctor, a nurse who will receive the person. And that's what we call by direct referral to the HIV unit. That includes all these steps. Now, we have improved also that process. In 2012, the average time was 14.2 days, and in 2021, it's 5.3 days. So probably nowadays, in less than 1 week, somebody will have an appointment in the hospital. There are two exceptions. If somebody has low CD4 counts, if it's below 200, or if we are talking about an acute HIV infection. In that case, you can see that also, the referral will be done in the next working day, and in the practice it's 1.6 days. People who who are in this situation will start treatment the same day they arrive at the hospital. We also prepare people who are undocumented to get them a health card, so they will have access also to care and to treatment. And finally, we offer also the person to come back after the visit in the hospital, so they will have, if they have questions about treatments, doubts, they will still have the opportunity to discuss that. So we were talking, and we heard about acute HIV infections, and that's important. That was already mentioned. The transmission is 10 times higher than in the chronic phase, and so we launched in 2014 a campaign and said, people, if you have regular sexual encounters, please come and test every 3 months. And this was a campaign. What the other thing is, once we had the gene expert already in the organization, we offered to not to everybody because of the cost, but to some people we offered to do a PCR test to see if there's an acute infection. If the PCR test was positive, we do a second PCR test, the viral load test, to see if it's confirmed. And here you can see the results. So it's an average of 7 acute infections we detect every year. That represents around 10% above the number of detections we have. But it's also important to think that these are cases which are more causing more transmissions than the other ones, and they will start treatment the next day, so they won't transmit it to other people. The other thing is that we were looking about the criteria. Who are you offering the PCR test to? So in the first year, we did around 160, we used 160 cartridges to detect 1 acute infection. And now we have cleared this criteria, and we use now around 30 cartridges to detect 1 acute HIV infection. So the benefits, we will listen later on about U equals U, but here you can see this is a study done by the hospital where you can see that the time from between infection, so not between diagnosis, but between infection and treatment is 69 days in 2015, and it went down to 46 days in 2019. On the other hand, we are following people who tested HIV negative, and we follow them during a time to have a cohort. And so in the cohort, we saw in the early years that the HIV incidence was 4.2 per 100 years, and at the period of 2015-2017, there was a drop of 60% in HIV incidence, and that was also published in the International Journal of STD and AIDS in 2020. So HIV testing is important, but it's a central step if we want to go further. It's important to detect HIV cases and to get them to treatment as soon as possible, but it's also the first step for people to get them to PrEP. And that's why in 2017 we created a second community center which is called BCN PREP Point. At that moment, PrEP wasn't approved yet in Spain. PrEP was approved in 2019. So it was already to create awareness in the community about PrEP. And between 2017 and 2019, we participated in the Discover study. We participated in 2 feasibility studies by the Spanish ministry and the Catalan ministry. But we also provided harm reduction programs for people who bought PrEP on their own. At that time, you could buy it online in the UK. It was still part of the EU at the time. So before PrEP was approved in Spain, we had already 1,200 people on PrEP. And I talked about the feasibility study, the Spanish feasibility study, which looked compared to provide PrEP, which is the best context to provide PrEP, HIV unit or an STI unit in the clinic, or an external STI clinic, or a community center. So there were 4 centers, but let me just point out to you that in the community center, 162 of the 300 participants were recruited in a community center. So the recruitment was faster. And the second thing is that, And the second thing is that the retention after 1 year was 92% in the community center, a bit higher than in the other centers. So that was the reason that the Barcelona PrEP Point was conceived as an official delivery center for PrEP in 2019. See also how incidence dropped 20% after people starting on PrEP. And this is from the end of 2019 till the end of last year. You see that we are providing at this moment to more than 2,300 people PrEP. In the whole of Spain, with 200 centers, there are 9,000 people on PrEP. So we, in one center, are providing more than 20%. Now, what are the main challenges for PrEP? I think there are two parts. One is to identify persons and who can benefit of PrEP and get them started as soon as possible. The first thing I would say, talking about sexuality in a context of a hospital is not very very convenient, and sometimes people don't feel very comfortable to talk about it. But let people decide themselves about what is their choice of prevention. That can be PrEP. It can be PrEP for a while. Maybe people can stop PrEP and start again later on. People know what's their sexuality, what's their activity. Let them make the decision. The other thing is about using words, language like high risk might be stigmatizing. Because just do an exercise, say what you want to say, but use instead of high risk, say sexual encounters. You will say the same thing, but you won't use high risk. What means high risk? High risk means that you have a high chance in a context where HIV incidence is very high. So if HIV incidence is very low, although you do the same thing, you don't have the same chance or probability to acquire an HIV infection. So let's talk openly and don't use use these words. The other thing is, when we talk about PrEP, there's a lot be talked about risk compensation. Now, risk compensation is about STIs rising, coming up. It's misleading. It's not evidence-based. There are no data which show that. What we know is that we haven't done any screening on STIs. STIs weren't obligated in declaration, so we didn't know how was the situation before PrEP. So what we see, and now data are coming in little by little, is that we see that people who do testing on a regular basis and get treated, we see that STIs are really going down. And finally, PrEP programs, why don't we try to combine them with other programs? Programs for key populations. It could be, I have an example here for HPV vaccination programs where you use and talk about PrEP, but it can be anything. That's really depending on the situation of the region. The other challenge is to retain people in the program. It's important to get people started, but PrEP is only going to work if people are staying on PrEP. So Dr. Nelson said that we could have learned a lot about COVID, and actually we learned about in the period of COVID, because the people who were on PrEP, more than 40% wanted, although we had a total lockdown in Spain, we saw that people wanted to stay on PrEP. So we sent medication to home, we sent an HIV home test. So why can't we incorporate that? Why can't we do things? Should we do testing every 3 months. People living with HIV are checked every 6 months. But somebody without an HIV infection, but on PrEP, will be checked more than people living with HIV. And also, the guidelines should be developing. We have to incorporate new technologies like apps, make people part of the decision taking. And let me just finish with this. Can we eliminate HIV in the future? And this is a study which was presented on the CROI during the last February, where you see all the different prevention methods, and if we take them away, how would HIV incidence increase? And so you see the different numbers. So taking out condom, twice you have the HIV incidence, but the combination of everything is a synergetic effect, has a synergetic effect, would means that HIV incidence would increase 11 times. So they did this mathematical modeling and showed that HIV could be eliminated virtually in a period of 25 years, with an interval of 17 and 33 years, if we maintain and increase combination prevention. So with this, I want to conclude my talk and acknowledge all the members and staff. Here you see a photo of a visit of the Catalan health minister, and I would like to thank you for your attention. Thank you.